Hello.
Hi.
Hi to everyone. And then also hello to Devra, who, even though we both live in Chicago, we hardly ever see each other. I
We
mean, even
do. It's true.
okay, let's see if that works. There.
Oh, that's
Okay.
fun.
A little bit more of us.
I'm gonna fix my hair. My hair.
Okay, everyone, I would like to take this opportunity to introduce Devra Sheldon. She is a physical therapist and owner of Devra Joy LLC. Through one-on-one mentoring, she guides learning experiences for clinicians who are working with patients who experience persistent pain. Within these interactions, she helps clinicians develop skills to address patients' strategies for self-management in order to reclaim their joy and function. She has been in practice since 2004 and has been board certified in neurology since 2009. Devra works in Chicago, focusing on low-income and minority populations with persistent pain and neurological conditions. She has a special interest in the clinical impact of sensory processing on rehabilitation. And we should chat more about the low-income and underserved minority populations
Yes.
sometime.
Yes. We can do that a lot.
I would really, really love that. Maybe we do that like a Facebook Live or something.
Yes. Yes.
Okay, too much fun. Okay, we'll stop planning our after conference events. And I'm going to invite Devra to show us her show and tell object.
I brought rocks because I love rocks. These were my grandma's. This one is a fire opal. This one's a rhodochrosite. I have lots of rocks in my house. Sometimes I'll have rocks in my jacket pockets. Here's a nice big labradorite with that blue. Whoa, that was a good one. And then I have a little malachite egg here. My kids like rocks. They have them as treasures. I make things with rocks. That's what I have to share. They're pretty, they're colorful, they remind me of my grandma, and I have a lot of them.
I love that so much, and they are beautiful rocks, for sure. Okay, so Devra and rocks, and now we get to listen to her wonderful talk, Persistent Pain, Shame and Stigma in Clinical Encounters.
Hi, my name is Devra Sheldon. I am a physical therapist, and today we are going to talk about shame and stigma in clinical encounters in pain care. Oops. Dr. Erin Lazar is noted as really introducing the topic to the medical field. While shame and humiliation and stigma had certainly been discussed in a psychological realm, his article in 1987 really forced us to take a closer look. The word shame means to cover. Shame is about being devalued in the mind of another. Stigma is about holding a characteristic that goes against societal norms. The harm from stigma comes from the internalization of it, that not just that I hold a characteristic that is devalued, but that I am bad. Now, Dr. Lazar discussed the circumstances in which shame could emerge. He discussed the nature of the disease that may, for example, be embarrassing, whether it's a particular body system, or may be considered of a moral failing like addiction. The vulnerability of the individual, how prone are they to experience a feeling like shame, and the social context of the interaction. Dr. Dalazal talked about body shame and shame from judgment. Now, the experience of shame is not just of the mind, it is also of the body. It is the autonomic nervous system. So we have the stress response on the sympathetic side of things and freezing on the parasympathetic side. And you see here a raccoon demonstrating a fine example of freezing. We see an increase in pro-inflammatory cytokines, acetylcholine, cortisol, adrenaline. Now, when 915 people were surveyed, a general health questionnaire, 84.3% were white, 77.5% were college educated, and half could recount a shame experience with a physician encounter. They found significant correlation between lower income levels and shame experience, and over half had ongoing negative feelings about the experience. Shame is a self-conscious emotion. It is about how others view them, and that thought is brought into their consciousness. There are 6 self-conscious emotions. We see shame, guilt, detachment, which is disconnectedness, externalization, which is projection, mental defeat, which is a sense of hopelessness, a loss of agency or autonomy, and fear of negative evaluation. Now, when these authors, when Turner Cobb and colleagues looked at individuals who had chronic musculoskeletal pain conditions and healthy controls, who were identified as highly limited on the Roland Morris Disability Questionnaire, they found significant differences between these groups. The individuals who experienced ongoing pain had clinically significant levels of shame, guilt, lower detachment, fear of negative evaluation, and mental defeat. We saw large effect sizes with shame and mental defeat, medium effect sizes with guilt and fear of negative evaluation, small effect sizes with externalization and lower detachment. But mental defeat was significantly correlated with disability, which makes sense, right? If I don't feel that I am capable of doing what I need to do, then I'm probably not going to do it. What I think was particularly interesting here was that the subjects who experienced ongoing pain had less detachment, as in they were more connected. And it just seems inextricable that people experiencing shame wouldn't become more detached, right? It's uncomfortable. Surely if we were more detached, we would feel less valence in the judgment of others. The answer, we'll have to wait and see. Sorry. The social threat of shame. Self-discrepancy theory is about the tension between the ought, actual, and ideal self. And it requires a constant surveillance of where am I? What is my identity? Am I living up to the expectations that I think I should be? And we see stigma consciousness, social evaluative threat, status anxiety, relational devaluation is all about my status compared to somebody else. So why are we so worried about the judgment of others? The answer, dinosaurs. Now, when we look at fossil records, there's a lot of injuries of different severity, of different healing times. And what we know is that we see in fossilized tracks is that it also impacted their mobility. We see different footprints, we see different stride lengths, we see quickened steps that may look asymmetric. And while we can't necessarily see behavior, and we can't know if dinosaurs felt pain, we don't know if they had accelerated healing times, the conclusion has been made that in order for them to have survived these injuries, they would have required help. Help with food, shelter, protection from predators. And in order for that help to have occurred, they would have needed a group of other dinosaurs to support them. So we see herds and packs and families. And when we look at fossil findings, they're often in groups. And this is the conclusion that has been made, that dinosaurs lived communally. Now, when we think about how they would have communicated to the group there must have been some level of social communication, whether it was in a behavior or a vocalization. And today, in birds and reptiles and crocodiles, which are our modern day correlates to dinosaurs, we see distress calls. We see squinting when there is pain. Human evolution theory tells us that with the evolution of humans 2 million years ago, we saw a doubling in the size of the brain. And social intelligence hypothesis surmises that it was in service to understanding the community, the relationships, the hierarchies, and all of those interpersonal interactions that are required to maintain that group. So things like thinking and reasoning and metacognition all had to develop for survival. We care for young and infirm, and we protect them from threats. And we don't just do this out of charity. There wasn't a dinosaur charity to help other dinosaurs. We do this because of reciprocal altruism. That when you consider how much risk helping may have incurred, I didn't do it for nothing. We helped because we thought the day might come where we also might need help. And so while I might help you now, I expect that eventually you will get back on your feet and help me when I need it. It's about mutual aid. Shame alerts us to risk. It tells us about our social standing, our potential devaluation. And if I'm at risk of losing my social standing, then I might lose my worthiness of care, my access to resources. I need my group for survival, and I need to be able to access the group and communal benefits. And what we see over evolution of varying species is that those individuals who maintained the strongest bonds, the best communication between other group members, they were the ones who survived. They were the ones who reproduced. And when you consider the effects of excommunication, right, was certain death and increased survivability for those who remained because there were more resources to allocate amongst them, less to share. Social pain theory tells us that threats to our social standing are threats to our survival. If we are excommunicated, we will die. We and the remaining members get to use the resources that I'm no longer using. Shame is a social pain. So when we revisit this slide and look at the social threat of shame, what we are surveilling is our social standing. And the feeling of shame and stigma actually invokes greater sympathetic responses than threats that don't question our social standing. This is about our perceived risk of our survivability. That if I am devalued, that I will not get resources and I may be excommunicated. And if we lose our group, who will support me? If I am not able to care for myself and I require ongoing support from the group, perpetually needing resources, then it is a challenge to the idea of reciprocal altruism. And to the observer watching the person who is expressing a need, I need to assess if they are worthy of access to those resources. Can I depend on them if I help them get better? And when we are appraising this from another member of our group, we are looking for social cheating. We are looking for the lie. and we are looking to judge what is the truth of the pain expression. Social threats, belonging, agency, and justice. When a person is experiencing pain and there is no clear diagnosis, this leads to threats of that social contract of reciprocal altruism. Now, the 1800s were a pretty interesting time. We did not just suddenly believe the things we believe today. We inherited these thoughts. They were passed down over time. And the idea of objectivity was really solidified in the 1800s. The idea that truth required direct observance, and what needed to be observed was the body. And that only the practitioner can identify what the truth is, and that subjective complaints are not evidence. And what we see in the 1800s is medical advances such as the stethoscope, the roentgen. So we were literally able to listen and see inside the body to identify what the truth was. Now, the 1800s also brought the railroad. And as railway travel grew, so too did railway accidents. And where there are accidents that are the result of major corporations, there is tort litigation. And what we see in the court proceedings of the time was an emphasis on proof. Without a lesion, there is no disease and there is no compensation. Now, there are structural barriers to the idea of proof and legitimacy. If you do not fit into a diagnosis code, an ICD-10 code, there is no disease, and you get no allocation of resources. And without a diagnosis, other groups that you associate with might also question your legitimacy if you are not legitimized within the medical context, right? If your doctor cannot come up with a diagnosis, then maybe it's all in your head, and maybe I shouldn't really be helping you this much at home, right? It can spill over. Our system is built on objectivism, and we rely on our communication to communicate our need state. And observers are appraising for social cheating. Now, these authors looked at 40 lay individuals, and they presented them vignettes where medical explanation was either clear or ambiguous, and psychological factors were either present or absent. And what they found was that when medical information was ambiguous, the observers experienced less distress, sympathy, desire to help. They appraised their pain as lower, and this was regardless of any psychological factors. They found no interaction with these factors, and they reran their experiment with more concrete psychological diagnoses, and the observers experienced even less distress. They concluded that the observers were looking for proof and that they weighted medical information more heavily. And when higher pain reports occur and they are not associated with a thing you can see, it creates more uncertainty in the observer, and it can influence the observer's use of contextual information. Now, when we look at this with different races and ethnicities, what we found were that for Black patients, contextual factors did not influence care decisions as it did for white patients. And while care for Black patients may look more consistent across ambiguity scenarios, it leads to questions of over or under treatment, perhaps more protocolized treatment. When we see this mismatch between what a patient is feeling, their expression, and their caregiver appraisal, it increases our sense of uncertainty, and it makes us feel uncomfortable and withdraw. When there is a lack of proof, we tend to discredit the expression. Lower pain assessments are made, and when we have lower pain assessments, certainly that would influence treatment. If a lower pain assessment is appraised and less resources are offered, might the individual believe that they have been treated unfairly or unjust because maybe they are being treated as they are inferior? Now, Miranda Fricker is the individual who came up with epistemic injustice, where the provider has attributed a deficit of credibility, that delegitimizing narratives of pain is a form of testimonial injustice. It is stigma. When 86 subjects who experienced either work-related injuries or motor vehicle accidents were assessed, all were found to have clinically relevant levels of injustice. They had increased pain expression, duration, depression, increased disability, and the presence of injustice predicted outcomes. And they are sticky. These feelings do not go away easily. And of the individuals surveyed, over half identified healthcare practitioners as one of their sources of injustice. They felt that practitioners didn't adequately assess their pain, they felt they were punished, and they felt they did not receive proper care. They felt that the social contract was broken. They should have been given resources. They are worthy of receiving resources. They are worthy of feeling that their social standing is high enough that they should have been allocated support. Now let's look a little more deeply at contextual influences. Social safety cueing would suggest that when there's more threat, I would express my pain more, because I really want this individual to think well of me so that I am worthy of care. But evolutionary considerations may tell us the opposite, that if a threat is nearby, a possible enemy or predator, then it might be safer to withdraw, to quiet. Think about those patients who suddenly stop cooperating, the patients who suddenly get quiet in the interaction and no longer really give full answers. They're withdrawing. They are perceiving a social threat. They no longer feel safe. For individuals who scored higher on the PCS, so increased levels of perceived helplessness, feeling as the worrying that their pain won't go away, worrying that they're unable to manage their pain. In those individuals, when social threat is increased, pain intensity ratings also increase. And the experience may hurt more because it is perceived as intentional. It seems unfair. But secondarily, when social threat was increased, they also had less facial expression. Overall, whether the individuals scored high or low on the PCS. And I want to pause here a moment and talk about facial expression, because it is used as a proxy for pain expression in studies and in practice. And it's important to remember that not everybody is going to exhibit reflexive facial expressions. Plenty of people have flat affects related to depression, medication they are taking, or maybe they have autism spectrum disorder. And it's really critical as caregivers, as healthcare practitioners, that we remember that. And that if someone is presenting with a flat affect, it is even more important that we listen to their words. When someone is experiencing shame or stigma, we see both approach and withdraw behavior. And when we look a little deeper at why that might occur, why both scenarios can exist, what we find is that risk mediates the shift from a desire to restore and protect to just protect. And that if the task required to restore my standing becomes too difficult, then I will revert to just protect instead of restore and protect. And what we see within our structures is that healthcare practitioners are the expert, are the truth seer, and that in that identity of us holding ourselves as expert, it requires that innately the subject who we are appraising is of a lower status. It disempowers the patient as experts of themselves. The provider's observance is valid, the patient's is not. It is us versus them, patient versus practitioner. Now, the patient is reliant upon the practitioner as a gatekeeper to resource allocation. And this really opens up a window of opportunity for intimidation and oppression. And within societal structures, we see in-group and out-group with marginalized individuals and the impact of stigma and structures and systems that are built upon those who are in the in-group building those structures. Chronic shame can emerge from minority stigma. Certainly, the dynamic of trust is important in clinical encounters and can influence power dynamics. There's things within our healthcare structure that can contribute to distance and indifference on the part of the practitioner. Protocols focus on technical proficiency, our perceptions of what is professional. Within our medical education, we spend a lot of time on addiction prevention and addiction management and less time on pain management. And we see historically racist teachings about pain that were still being taught not that long ago, and unfortunately some of which are still taught today. Within our education of medical professionals, the body tends to be de-identified. And the rigor of training shifts our moral valence away from social relationships and towards work, job. Mom, I can't come home this weekend. I have a big test I have to study for. We start to prioritize work over family. We prioritize what we have to do to raise our social standing over maintaining our social relationships. We start to focus on efficiency, rationality, emotional detachment. And when we see, when there's pain expression and there's increased social threat and we are unable to pursue our social roles because we are in pain, we start to question our identity. Who am I if I cannot do this thing? And if I cannot do this thing, then I may lose my standing. And I might worry about my ability to rely on my group for support, for resources. But this doesn't have to be the way. We can prevent shame. We can validate to prevent the loss of their sense of social standing. Gilbert and colleagues offer the competencies of compassion. There are 12, and they split them into 6. That inner circle that they call the first psychology, that is engagement. It is choosing to be present, choosing to care, being aware. It is being intentional. It is being present with the distress of others without dissociating from it. It is about being sympathetic and sensitive to the individual in front of us. The second psychology, that outer circle, that they term action. These are the things we actively do. We actively focus our attention. We use imagery to rehearse and practice our interactions. We use reasoning to problem solve our situation. We are mindful of our behavior, our body postures, our communication. And we make sure that we understand the context of our feelings as practitioners when we are in that interaction. Quintner and Cohen talk about intersubjectivity, that third space. And while patients are also reconciling their ought, actual, and ideal selves, practitioners also are reconciling those tensions. And we have competing efforts to sustain our identities. Mutual desire to recognize and be recognized. And the idea of the third space is that each of us can live within the experience of the other, and that they are inextricably linked. And the idea of social prospection, which is similar to Gilbert's idea of imagery, is that you can practice these interactions, you can mentally rehearse them to help foster this third space. Now, we all know about therapeutic alliance and what is important and necessary to build those opportunities for engagement. Being present and receptive, being open with your attitude and focused, making sure that you're managing your personal agendas, and attending to the patient's communication. These are things that help us move closer and close the gap of distance and indifference. Certainly being genuine, being yourself, honest, transparent, and direct. Curbing your judgment, meeting the person where they are, and making sure that you're investing in the personal, showing interest beyond the reason for referral. And this doesn't have to be personal in order to be personable. You don't necessarily have to divulge things that you think are private. You could find a shared interest. How many physios talk about sports with their patients, right? Now I want to focus for a moment on the idea of commitment, because I want to focus on the idea of action, the idea of committed action, which is somewhat a proxy for buy-in. And I think it's important for us as clinicians to be aware of how we are appraising that. Earlier in this discussion, I talked about when there is shame and perceived social threat, we see both approach and withdrawal. And it's important that we as clinicians don't conflate that as not having committed action. and that we need to ensure that we are not inadvertently creating shame or stigma dynamics that impact the patient's participation and their desire to be there with us, to feel safe with us. And last, I want to talk about the social communication model of pain. We have been operating from a biopsychosocial framework as the most dominant model that we discuss. And people talk about reordering it and applying it differently and everything that isn't working about it. And what is missing from it is that it all occurs within a social context. Biopsychosocial doesn't help us understand how the factors are interrelated and how to apply it in care provision. But the social communication model of pain puts biopsychosocial into the relationships between practitioners and patients, between people and their loved ones. It is the social of biopsychosocial, because it is within these interactions that devaluation occurs. And that is what leads to shame and stigma and questioning our identities and our social standing, leading us to worry about our survivability. And I want to focus here on the bottom part of the model. Prior to any pain event, we have everything that has happened to us or been experienced by us or biologically occurred or socially occurred or happened genetically or within our cultural history or family, all leading us to that moment, and it cannot be separated out. And once an event occurs or the initial experience of pain occurs, we have all of those same factors influencing how we experience it. Whether it is prior knowledge, socialized meaning, right? Prior experience, social emotional development, all shape our pain experience. And from our pain experience emerges pain expression, our communication to the world that we need support. And how we communicate that is also determined through biology, socialization, family, culture. And our pain expression is to communicate with someone else. And whether that is a caregiver or a healthcare practitioner, your doctor, your physical therapist, we then, as the practitioner, must decode and appraise that expression. And once we do that, we make a decision about action. And the moment we act, whether it is verbal, a treatment, a facial expression, a body position, then it immediately becomes part of the pain experience. And once that happens, we are inextricably linked to the cycle of the pain experience. We cannot be separated from it. We are of and with the practitioner. And with that, I want to end with a Maya Angelou quote: that people may forget what you have said, people will forget what you did, but people will never forget how you made them feel. Thank you. Oh,
okay. Hi, yeah, we're back. So it's time for questions. I am looking, we had quite a few people watching, but I don't see any questions yet. Anybody?
It's okay. It's all right. We can just talk about it ourselves now. Oh, a cat.
No,
Oh,
so yeah, that's Jack. He likes to help. The what did you think, Jack? The so one, I really love your talk, and there's just so much where I think we don't consider how much we impact what we're doing, and what an impression we make. Now, that person that we might have seen 10 times, or that one person we saw that one time. So I really loved just bringing all of this up. And also, Rajan reminded me there's going to be a little lag, so hopefully we'll be getting some more questions here shortly.
That's right. We can fill it in. We can fill it in.
Just keep filling. I love it. So have you always been like this, or did something happen that made you go, things could or should be different?
I would say that it is a pretty common feature of my life that I'm the person that asks the question that is annoying, or asks why when no one wants to consider why, or things like that. So it's kind of nice in adulthood to be able to go down those rabbit holes myself, and not have anyone be annoyed that I'm asking, because I can answer it myself. I can investigate on my own. And I think this is something that we just aren't taught, right? We're not taught, so we don't know. We know it exists. Yes, that sounds nice. But I think the fact that as healthcare practitioners, we are inextricably linked to the individual's pain experience is something that we really need to hold with care. I think it's easy to assume that there's this very transactional kind of approach, and we can't see inside the person's head, but there's enough evidence for us to know that we need to pay attention, to how these interactions play out. And when you look at how predictive of outcomes some of these elements are, it raises the question: if I treat shame, if I treat the identity, if I, make those my targets, I think we could call that treating pain, right? Looking at helping them feel like they are still part of their group, that they are able to participate, because then they feel like they're still in good standing within their group. And it kind of helped validate, I think, a lot of what I know, how I practice, how you practice, how lots of other people practice, that other people might think of as, well, is that really being a physio, or, and I think it is. And I think this kind of helps bolster that.
I agree.
Yeah,
that was so well said.
I knew you would agree. I knew.
And now we do have some questions from the participants. So here comes the first one of: how do you think the healthcare system is supposed to change?
I think we need to start before the healthcare system, right? I think some of these are cultural expectations and educational expectations. How are these things taught in school? I kind of pointed out that there's this emphasis on, addiction prevention instead of pain management. I think that, at least for the PT students that I get, while they are taught the biopsychosocial model, they don't really know how to apply it, and they certainly don't understand how they factor into the equation. Changing a system is hard. Obviously, requiring a diagnostic code and as a gatekeeper to care is exceptionally problematic. But I think it starts with more awareness amongst healthcare practitioners, and I think that comes with a very big push towards better pain education, and how robust and full that really needs to be in school. Something that I picked up on in my reading was that a lot of times some of these dynamics are modeled for students by seasoned professionals, right? And how we talk about patients. Oh, this is a difficult patient. Or, patients that are able to give us what feels like more concrete, objective information somehow feels like a good patient, and kind of working on that comfort with discomfort and not appraising the value of the individual based upon your comfort with what's happening. And, obviously there needs to be a radical shift. I think there's a lot of us that model this, right? I think that I model it for my colleagues. I model it for my mentees. I model it for my students. I certainly model it with my patients, right? So they know that there can be another way. Does that answer your question?
Awesome.
Maybe.
I don't know if they're going to let us know, but I think so. I think that was another great answer, Devra.
Thank you.
Okay, I'm going to do this one next. There's a couple more words that didn't fit on the slide. So the presentation brought to mind the current conflict in the culture between wearers of masks and observers of extreme social distance versus others, the challenge of power and challenge of community, and other ideas in that vein.
So this is a
I don't know if you have
statement, not a question, right?
More of a statement, not a question.
Okay. Well, it sounds to me like there are people who, part of your, I guess, identity is that you're in a group who believes and values, mask wearing versus being in a group who believes and values not mask wearing. And I am definitely not an expert in social behavior, but, based upon kind of everything I've learned, it's about wanting to feel included in your group, right? That is, our social standing is really important. It is it helps us know that we will survive because we are supported and that we are firmly within our group, right? We are not outliers. We are not at risk for excommunication, right? So I think to some degree it becomes about group identity. Does that, I see it everywhere. I can tell you that I see these themes all over the place. So there's not much you can bring up to me that'll be like, yeah, no, I don't think that applies. I think it's everywhere.
I love it. And you've really inspired a lot of comments, and we're going to get to a question. But this one I just wanted to share with you. Wow, thank you. No question, but just can't wait to listen to this several times.
You're very welcome.
Okay, so here is a question. How do you think we can start to restore equity to marginalized populations in healthcare?
Well, so I've been a clinician for 16 plus-ish years now, and about 14 of them have been working with low-income populations. So I think there's a whole lot that we need to consider and do. I think that we have and I can only speak to my knowledge of healthcare systems in the United States, but there's massive amounts of inequity in terms of access, right? Hospitals and practices that accept Medicare, for example, are not required to accept Medicaid. So that is our kind of low income and state insurance. And while I understand, smaller practices, it's far less feasible. We're talking about massive systems, massive health systems that severely limit how many patients with Medicaid that they'll see. And when I say massive health systems, I mean hospitals with huge networks, right? I'm not talking about the small guy. I'm talking about the huge guy who's taking lots of government dollars, are not required to see these individuals. And while they technically can't deny them care, they come up with all these little rules that limit access. And I see it over and over and over again with my patients. There's even rules about, so let's say, and I'm going to dig on orthopods, I'm so sorry, but they, to make some extra cash, you'll pick up call in an emergency department, right? So you take the overnight shift, an emergency comes in, somebody needs surgery, you do it. Because maybe it's a smaller hospital that doesn't necessarily have a large enough ortho staff to cover that, and so you can pick up call. Private ortho groups can pick up calls. And let's say a person has surgery, that person only has 30 days to follow up with that physician. So they have a problem 6 months later, there is nothing they can do. They are not obligated to follow that person. So there are so many access related issues. While transportation is technically covered, it's horrendous. It's so bad. And, you know, it would be easier to give people, you know, like PACE, you know, versus some of these transportation companies and things like that. You know, we also, you know, in addition to access, you look at, you know, how many hospitals are clustered together. And in Chicago, over the last couple of years, we've had several hospitals close, and they closed in areas that really needed them. So, you know, I think access is step one, you know, and I think educating about how different populations have different health needs is also really important. And I think sometimes some education touches on it, sometimes well, sometimes not well, but really it's not enough. It's not clear enough. It's not respectful enough. You know, there's certainly huge pushes for more diversity amongst healthcare practitioners. When you look at appraisals of pain, for example, or you look at, you know, I was talking about evolutionarily speaking, that we have our group, right? So we are biologically and evolutionarily more inclined to understand someone within our group. So having a Black physician treat a Black patient is different, right? In a way that I can never know, right? And having more practitioners who look like their patients is really, really important. I could go on and on and on about this. It sounds like Sarah and I have a plan for that in the future.
Definitely. So I've actually been part of some conversations on physical therapy in particular, but how we're not a very diverse profession. And then really like taking it back a couple of steps to see why. And it goes back to like the systemic issues of, you know, just even having access to the courses in high school or even elementary school that would put you more likely to be able to go to college, period, let alone take the classes that would be necessary to be the prerequisites. And then also, you know, like socially and financially, becoming a PT costs a couple dollars, and
more than a couple. Yeah.
But yeah, so just it's a much bigger problem. But I think I agree again that yeah, if we can get more people who are diverse to work with those populations who look like them, why would you listen to me? So yeah, so I think that's a more awesome points. And here's another statement.
Okay.
So what a paradox, a marginalized individual being offered less care that might be consistent with guideline care, perceives an injustice, leading to dissatisfaction and reinforcing the victim role.
So I think you're kind of, there was definitely like two studies that I was talking about. In the study that talked about what looked like more consistent care for Black patients versus more variable care for white patients, they didn't touch on the these were not real patients, they were vignettes. So they didn't specifically go into how that care was perceived. But there's definitely other evidence about, you know, less distress, lower pain appraisals, you know, things like that. And my personal experience of 14 years working with marginalized groups, they often don't even recognize the injustice because it has sadly been so normalized. It's what they're expecting. So it is not uncommon for me to hear a patient recount an interaction, and inside I'm having like silent rage about it. And I kind of just hold space for them because they're telling me something important to them. And it's fairly common that it's just, you know, because I'll say, oh, well, did you ask about this? Or, you know, what happened? You know, just sort of getting more information. And they're like, I don't know, it is what it is, right? Like they've been gaslit for so long, they think it's normal when it's not. Um, but, yes to all the things. I mean, there's so many spokes and like going off in so many tangents we can do with this topic. There's a lot.
Yeah, so much.
Yeah.
And now we have a question from Eddie. How can you foster the therapeutic alliance without falling into the trap of being part of their us instead of them?
Being part of their us instead of them. I work very hard at this in the sense that I reinforce many times over during our sessions that they're the important one here, right? It's not about me. It's what do you think? It's right. People are so accustomed to, going to practitioner to, get care, to get their advice for, whatever, but it is an active process to help somebody continue to feel that they are important and they are listened to. And it's not just like I did this one thing once. It is every interaction, the entire session. It is how I document even, right? If you were to even just read my documentation, you would see significant deference given to them over me. And I think it needs to kind of become the whole thing. And it just becomes who you are as a clinician, I think. And it takes practice, right? It's not like this just happened overnight, right? Because it's so different, I think, than how we're taught, right? We're taught that we're movement experts, right? We're body experts, right? The whole medical model is predicated on my expertise over theirs, right?
So that then I don't see another question on the list, so I get to ask one.
Oh, great.
So what do you think needs to happen in the training of healthcare professionals to perhaps shift the needle a little sooner?
Yeah, I think that, there's so much we could do. Obviously, I think we need to be learning different things, but nobody, when you look at how things are taught in medical school and physio school, and, we have everything is compartmentalized, right? You learn about orthopedics, you learn about neurology, you learn about, physicians are going to learn about endocrinology, emergency medicine, right? And nobody wants to give up any of their time or content, right? And nobody wants to make school longer. And nobody, one of my issues that I've said about pain education is that it is like this add-on as opposed to themes carried out in every class, right? That there is consistent language, that there's consistent messaging, because if we're going to continue with pain is complex, it is emergent, it is this, then we need to carry that thought forward when we're learning orthopedics. And it just doesn't happen that way. So I think that instead of looking at it as this burden of something we need to teach specifically, I think we need to relook at how we're teaching all the things anyway, and how can I modify that content so these themes continue to push forward. Is that?
Just trying to.
Yeah.
Oh,
sorry.
No, keep going.
Something else that came up that I didn't talk about, but I do see it with like physio students, and I can't speak to what medical students go through, but there's a lot more push to reflect on your interactions and your practice. And I definitely see physio students needing to, I have to log in and post my reflection and stuff like that. And I think those are really important opportunities that I certainly took for granted when I was a student. And, had I known these things, if it was, I want you to reflect on how you think that interaction could have maybe been better, right? What could have been different, and kind of like more specific prompts, knowing what we know about shame. I have a patient right now who, when I was reading the article on injustice, they were just like headlights in my mind. It is a huge theme for this individual, huge. And just knowing that, even though I have huge empathy for this individual, it just created this other level of understanding for me. And even just being able to say to them, that sounds really unjust. That's not fair. For them to be able to hear a healthcare practitioner say those words, right, and recognize it, I think is really, I hope is very validating, right? I think we have this idea of being professional and not allowed to say something negative about another practitioner. But I think we forget that sometimes it's those interactions that can be really traumatic. And I don't need to validate that. My job is for the person in front of me to feel supported. And I'm okay with saying that was awful. That should have never happened. I'm really sorry that happened, and kind of teaching people and empowering them. And I think that there's a lot between like student and instructor dynamics, especially medical students who are following attendings and watching those interactions, right? And they never kind of not decompress, but kind of like review and say, it's held as this is what you're supposed to do, and you need to get with the program, as opposed to reflecting and saying, maybe this isn't how I want to practice. Maybe I can do it different. And I think kind of using those reflective opportunities more, I think, is a really important thing for us to engage with.
Yeah, I actually really appreciate what you said there about, right, so you go to and you watch your attendings, you watch your clinical instructors, and this is how it's supposed to be done. And again, going back to the school idea of maybe we can do better empowering the students, future healthcare professionals, to go, okay, not how maybe I want to do this, or maybe not the best way to go about it. And I think that might be a little piece that I would like to do for students, is to kind of give them that, I don't know, permission, idea, empowerment. I don't know that it would have occurred to me as a student to question like that.
I question everything all the time, so no.
I do now, and it's like you said, now that you're an adult, you can just figure it out on your own, and you don't annoy people. I'm like, oh, I annoy people on the regular with my questions.
Do it.
Okay, so we don't have any other questions right now. Do you want to leave the large group with any final thoughts before we scooch over to the discussion?
I mean, I could talk about this topic all day. So I'm around if you want to chat later, if you have thoughts later, if you're noticing that you're simmering about things and you're just like, I really need to express this thought, or when I was going through this content, it was always like, oh yeah, and then this and this. And it's like literally the lens I see everything in. So I am here. Find me. You can email me if you don't see me on the platform, and we can talk about all the things.
Awesome. All right. Well, thank you so much. It was a wonderful talk.